Thanks for checking out this week's edition of Morning Report Emergency Medicine. I'm Alec Weir. I'm sorry if my voice sounds a little funny. I saw my first pediatric fever of the year last week, and the next day I came down with a little bit of a head cold, so here we go. This is the case of pregnant, altered mental status. 28-year-old female, she's a G2P1 at 36 and 3/7 weeks, no past medical history, coming in with acute onset of altered mental status 1 hour prior to arrival. She's also complaining of loss of vision, headache, and paresthesias, but no seizure activity has been reported. Here are her vitals. She's afebrile, heart rate of 78, blood pressure of 141 over 101, respiratory rate of 23, 97% on room air. Neurologic exam, she's A&O times 1. She's unable to tell you what year it is or where she is, but she's moving all extremities. Her cranial nerves are intact, but she does report diminished sensation to upper extremities. Her POC glucose is normal. You're going to get a CBC, a CMP, a UA, and then she's going to get her head scanned. And here we have her head CT. No obvious blood, masses, anything like that. Her ventricles are a little big. That gets mentioned on the report. Prominence of the lateral ventricles may represent ex-vacuole dilatation, or non-communicating hydrocephalus cannot be completely excluded. It was completely excluded later on in her hospital stay with an MRI. Her laboratory results, white count's up a little bit, hemoglobin's down a little bit, but her AST and ALT are both normal, as well as her platelets, and that's going to be important here in a minute. And her urinalysis shows she's got elevated protein. So what are we dealing with? So this is pre-eclampsia, right? Gestational hypertension, defined as systolic of 140 over diastolic of 90 plus proteinuria. And if you add seizures onto that, now you've moved into eclampsia. And the progression between the two is really unpredictable. Pre-eclampsia complicates 2 to 7% of pregnancies, and eclampsia is a major cause of maternal mortality. So what are the clinical features of pre-eclampsia? Kidney damage, edema, although this can be difficult to assess because pregnant women will have some physiologic lower extremity edema. Neuro findings such as headache or scotomata, which is that blurred vision or seeing floaters in your eyes. But then you have to be worried about HELLP syndrome. This occurs in 5 to 10% of preeclampsia cases, and this is hypertension, elevated liver enzymes, and low platelets. But as you can remember, our patients were all normal. So what are we going to do? We're going to give her magnesium, right? So magnesium helps to treat the seizures, and although it's not an antihypertensive, helps to decrease the blood pressure in preeclampsia. It's a 6-gram loading dose followed by 2 grams per hour. And if you need to, add an antihypertensive agent. Recommendations are hydralazine, nimodipine, or labetalol for these patients. And then you also want to be certain that you're looking for other causes of seizure if you have an eclamptic patient. Patient's hospital stay. She had resolution of her altered mental status. She did have some continued scotomata throughout her stay, but she delivered a healthy baby boy. So what are our take-home points? No one gestational hypertension moves to preeclampsia when you have things like kidney failure or proteinuria. And then no one it moves to eclampsia when you add seizures onto it. But remember, the proteinuria can vary. So when you do a spot test of the UA, it may be normal. Watch out for HELLP syndrome. Get those liver enzymes and check the platelets. You want to give magnesium, 6-gram loading dose, followed by 2 grams per hour. And you want to make sure you're watching for loss of reflexes and decreased respirations as a sign of hypermagnesemia. And then blood pressure control if you need it. You want to use hydralazine, nimodipine, or labetalol in your pregnant patients. All right, guys, that's it. Keep your eyes out for more interesting cases.